Okay, welcome back. I'm going to start a little bit early just because I do have a lot of material to cover today, and we'll get started. My name is Dr. David Kunashko. I'm the medical director here at BioFlex Laser Therapy. We are a medical device company focused on photobiomodulation therapy for both professional clinical therapists and clinicians, as well as direct-to-consumer devices as well. Today's topic is kind of geared towards healthcare professionals, but I think anyone that's interested in their joint health might find this interesting as well, too. Just so you know, these webinars are recorded, then they're edited, and then they're typically uploaded to our website, bioflexlaser.com. So if you need to leave early or want to rewatch it, or for future webinars and you can't make one, then you can just go to our website, usually a week or two after the broadcast. There you can find them on our website as well. Even if you just register, which is helpful, you'll get an email usually. Sometimes things go awry, but usually you'll get an email with a link to watch it so you don't have to go to the website. Okay, so today's topic I thought would be kind of interesting because it's a question that I get asked a lot by patients and even clinicians, whether or not laser therapy, of course, is now known as photobiomodulation therapy, if it can help repair or regenerate or grow hyaline cartilage, which of course is a cartilage of joints, articular joints. And I'm going to discuss this. Spoiler alert, the answer is maybe. So I'll present the evidence. I'll talk a little bit about how you might want to use the equipment to try this. But I also have a lot of information about this particular topic that I think will be helpful in explaining to your patients, or if you're a patient yourself, trying to understand what this type of therapy may or may not do. So I'll talk a little bit about hyaline cartilage, the structure of it, just as a review, a histological review. That's always helpful. And then I'll talk a little bit about how medical treatment currently, how they treat cartilage degeneration, and if it's successful or not, that kind of thing, where they're at with that. And spoiler alert, nothing is 100% successful, obviously. And then specifically about why photobiomodulation or laser therapy might be helpful in repair of cartilage to joints, as well as some of the research I'm going to present. And then I'll talk a little bit about using our equipment, again, geared towards healthcare professionals. But if you have any questions or you're using our home devices, I can certainly answer that as well, too. And then you're lucky, I will have a bonus rant of the day at the very end. One of our users, BioFlex users, sent me a link to an article about red light therapy from the Wirecutter and New York Times. And so I read the article. I found it interesting. I thought it was quite biased, and I didn't think it was, I'll leave that rant for at the end. And so if you're interested in that, I'll go over that a little bit. And then any questions you have, and I can try and answer those questions as best I can. So hyaline cartilage, of course, is articular cartilage tissue. It's extensively hydrated, meaning that it has a lot of water in it, but it's not directly innervated nor directly vascularized, so no blood vessels. And this, in part, makes it very challenging to try and repair or regenerate this type of tissue. It has a relatively low cell density. That is, there aren't many cells that make it up, unlike other types of tissue, like say for bone, for example. And of course, like bone has a much greater capacity for self-renewal or repair. Both in vivo and in vitro sort of reconstruction or restoration of hyaline cartilage has been a targeted goal by tissue engineering approaches for quite a while now. I'm going to talk a bit about that and where they're at with that, but you will still see that things like PRP are not recommended, so they say, yet it's so widely used. This is the part of the problem I have, is that when you talk about evidence-based guidelines, they're typically done by the medical profession that you may argue have an agenda with respect to how they treat as opposed to other options, but maybe that's just part of my rant later on today. All right, so despite lack of innervation and blood vessels, oh, by the way, ask me questions any juncture along these webinars, type them into the chat box, and I'll get to those at the end of the webinar. So despite lacking innervation and blood vessels, this type of tissue, it has several layers, and they all have slightly different organization, like different density and composition of ECM or extracellular matrix, and as well as orientation of collagen fibers. There's really only one single cell type, which are called chondrocytes, and these cells are in different layers, and they have very distinct morphologies and functionalities. So there's basically four zones of articular hyaline cartilage. There's a superficial zone. This is the one that would be in contact with the synovial fluid. So you can imagine if you were to touch, I don't know if you have, if you know, if you eat, say, if you're a meat eater and, you know, you break open a chicken wing. I know it's kind of graphic, but and then you touch the ends of the bones. That's articular cartilage. It's smooth, although it's, you know, been baked or fried or whatever. But you know what I mean. That's the part that part you're touching. That's a superficial zone, and it contains what's referred to as chondroprogenitor cells. In the middle zone, beneath the superficial zone, is called the middle or transitional zone, and it consists of round chondrocytes. So these are mature chondrocyte cells. Then you have the deep or radial zone, which then sort of connects into the calcified layer, which has a direct contact with the underlying subchondral bone. So those are the sort of layerings of hyaline cartilage. You can see it nicely here on a stained sample, histological sample from the bottom. So this is where you have the direct bone, you have subchondral bone, then you sort of have this sort of calcified zone that's sort of starting to turn into cartilage, and then you have the deep radial zone. You can see the little dots; those are chondrocytes, and you can see the shape and the density. They sort of flatten out as they go higher, or sort of more superficial. Into the middle transitional zone, and then finally that superficial zone where they're flattened out. These are the cells that are repairing. That's kind of the target when you're trying to do anything with repairing hyaline cartilage. Is this superficial zone, especially, that's very active and trying to repair, but it has a very limited ability to repair. It can repair, but it's kind of limited. And if you zone in on that, you can kind of see what I was talking about. So the round cells in the middle zone, then they start to flatten out. These are kind of the younger cells. And then as they mature, they go a little bit deeper and they form more layers of this hyaline cartilage. The consistency of cartilage, as you probably know, is like it's kind of like spongy but hard. I don't know if you've ever made like jello or gelatin, and then if you don't stir it up enough, there's a layer at the very bottom that's a lot denser and sort of harder, but still soft and elastic and plasticky kind of. That's kind of what it's like, but even more dense, if you can understand that analogy. So degenerative lesions of articular cartilage are basically a consequence of degenerative or destructive joint disease, typically OA, like osteoarthritis, but of course, rheumatoid arthritis, all these types of issues. And of course, it leads to disability and pain during movement of the joint and gradual deformation of the bone articulation. All that really means, of course, is that you have limitations with joint movement, like your knee or your fingers, and it becomes a real problem for doing activities of daily living. OA, which is the most common musculoskeletal disorder globally, it's 10 to 12% of the global population. Of course, that's increasing. And if you look at for people 65 and above, this is a little bit outdated because it's probably over 10 years old. They don't update it every year. Almost 50% of those over 65 would have osteoarthritis or signs and symptoms of osteoarthritis. And of course, this is just getting worse and worse as we have an older society. And of course, you know, being overweight as well doesn't help joint health. It's considered an issue as well, too. So again, if you look at what I was talking about on the left on your screen, you can see what I was referring to, sort of the calcified zone, radial zone, intermediate zone, and superficial zone. That's what healthy hyaline cartilage looks like. Then on the right is where you start to have erosions and degeneration. You start to have all sorts of interesting byproducts of synovial inflammation, proteases and different cytokines and chemokines that cause inflammation and pain and further degradation of this cartilage. So while your target when you're trying to help joint health is also the hyaline cartilage, but it's also synovial membrane and the inner lining of the synovial membrane that controls inflammation and actually has a big part to do with erosion of the cartilage. So you want to reduce inflammation as well as try and repair, regenerate as best you can with the hyaline cartilage. This is just another graphic visualization, in this case of a knee joint. And you can see that on a radiograph, on an x-ray, grade 0, there's a certain measurement we would do as clinicians to measure the distance and see if there's any deviation from normal. And then you can start to see grade 1, 2, 3, and 4 as you get the joints closer together on a radiograph. You're not seeing the cartilage, you're seeing the joint space. The joint space narrows as the hyaline cartilage, of course, degrades. And then you can see grade 4, which is literally bone on bone. In the knee, it's typically on the medial aspect. So you can see there, that would be significant wear and tear, and right down to the subchondral bone where there's really not much or any hyaline cartilage that's helped cushion that joint. So those are the candidates that would go on to usually have joint repair. Early OA is characterized by the infiltration of mononuclear cells. These are white blood cells, and that's what controls inflammation and prolonged degradation and articular damage. So you really want to try and get that under control. I don't think it's advisable to take medications for this. Well, I guess it depends, but a lot of times there's long-term side effects with like NSAIDs, that kind of thing, and especially temporary blockage of inflammation, that kind of thing. I think you're much better off to do like non-pharmacological ways of dealing with it. And there's many ways that can probably help. Maybe not the bang for buck, for taking a strong drug, but let's face it, it's not actually doing anything for the problem, right? So it's really just masking the issues and not dealing with the inflammation per se to any great degree. That's my opinion, but so synovial inflammation is an important source of both pro and anti-inflammatory mediators. There's certain interleukins, in this case, 1 beta and interleukin 6, and these are produced by synovial cells, and they induce this cascade of degradation that leads to further joint injury. If we look at sort of the way that medical doctors approach degeneration, there's multiple ways that they might look at it, from symptomatic procedures in clinical practice like COX-2 inhibitors and NSAIDs. And again, I'm not a medical doctor, so there's that. But I studied pharmacology in undergrad, and I have a good understanding of these different medications, and a lot of the times they're not really going to really help with underlying pathology. Then there's injections like corticosteroids and hyaluronic acid and PRP. If anything, I would go with PRP. They say it's not FDA approved. I bet you they'll never approve it, no matter how much positive impact there is. PRP is pervasive. You can see it lots of clinics do it, and that's because it helps. Athletes do it, people that have money do it, if they have access to it, because oftentimes it's very helpful. Yeah, it's not a panacea and it doesn't help everyone, but there's plenty of evidence to show that it's helpful. Maybe not the huge randomized control trials that drug companies get when they're trying to approve a drug, and that's where they get these evidence-based guidelines because of the thousands of people that they test. It's much more difficult to prove that with lower numbers of randomized control trials or subjects. And that's a part of the problem we have with laser therapy as well, too. Anywho, then there's restoration procedures. So there's surgical procedures, there's regenerative medicine, using different sort of matrix-induced chondrocyte implantation. They're really starting to look into this type of therapy, and I think it's still kind of in its infancy. So it's difficult to say where they're at with that. It's certainly not something that you could just go to your doctor and say, hey, I want these kind of procedures, because it's not routinely done. But, there's even future ones coming out like scaffolding and using different cells like mesenchymal cells, stem cells, especially stem cells. And there's natural cartilage environment, different lubrication things they're working on. So there's lots of things underway because it's such a pervasive issue. But nothing is conclusive as saying the gold standard. So there's lots of ways of approaching this. And I really, truly think that photobiomodulation is part of this process. Of course, you don't see it here because why would they mention it? Mike Sider, you raised your hand. I'm not sure why you raised your hand, but maybe type in the chat box if you have a question. I'm not sure if that was a mistake or not. Anyway, intra-articular glucocortical injections seem to be helpful for short-term pain relief, maybe lasting a few weeks or what have you. And so it can be helpful for useful adjunct therapy. But the long-term thinking of that is you don't want to have regular injections. And so you kind of, that may actually cause more issues with the joint health. So, personally, I don't think that's the best approach. Then there's, I mentioned PRP or platelet-rich plasma. The price of this type of therapy is coming down because it's being offered a lot more. And so I think it is a potentially good benefit, especially if it's not really severe arthritis. Oh, Mike just said he's carrying his phone around, so he bumped into the button. Okay, no worries. So I think PRP has a role to play. I think there's enough evidence for if you can afford it, because you're not going to be covered by your insurance or whatever, because why would they pay for something that's not a drug? I know I'm a little hypocritical, but anyway, I think that there's a potential for it to work. The studies are kind of like still coming out, and again, they're not part of guidelines to any great degree yet. But it's safe and it's easy to do. There's really no serious adverse effects, and it has a good safety profile. So, hey, like, why wouldn't you try it if there's decent evidence? Another promising treatment, as I mentioned earlier, are stem cells, like mesenchymal stem cells. These are derived from bone marrow, adipose tissue, or umbilical cord. I've anecdotally talked to a lot of doctors that do this type of therapy with seemingly good anecdotal results. I know they're not clinical trials, but they're starting to do more and more clinical trials and systematic reviews and looking at it. So there is limited high quality of evidence, but it seems that it may be helpful in the long term. Okay, so why do photobiomodulation or laser therapy? As many of you are aware, because you're tuning in, you probably know a little bit about laser therapy and how it works. It has multiple mechanisms. These are well established and understood for the most part. I mean, it's not clearly understood everything, but they've been looking at this for 30, 40 years. And I think there's pretty good science to understand what's going on with light inside these cells, including its effect on the mitochondria and causing an increase in ATP. You can see it here, and also a short spike in ROS, which are reactive oxygen species. And this triggers different pathways that help inhibit what's called apoptotic cell death, which basically protects the cell. So that's one way it works. And of course, by increasing other factors like nitric oxide and anti-inflammatory mediators, it can potentially help these cells repair and regenerate, especially through this ATP mechanism and preventing cells from dying, like chondrocytes, and helping them undergoing mitosis. That's called increasing the mitotic index. So if you do that, you have more cells that are viable and healthier, then they're going to start to repair. And I'll show you the evidence for this as well, too. Really, the only good evidence I have in humans is this particular paper that I've mentioned before, is radiological and biochemical effects of low-level laser therapy and chronic OA. The paper was done in Saudi Arabia, which, by the way, I visited recently for work, and I spoke at several hospitals there in Riyadh and Taif. And they're very interested in this type of therapy, but it's pretty new to them, even though you see some research that's been done there. But they're really accepting of it, but they still have to wrap their head around, how to use it and all the rest of it. But the response was quite good. Anyway, their objective was multi-pronged kind of. They wanted to look to see if it had pain relieving effect, if it had any effect on the biochemical, like inflammatory exudate surrounding arthritis, as well as seeing if there was any potential repair. And the thing about this is that it wasn't just subjective, like, improving pain, right? They actually did radiological before and afters to measure the joint space. It's pretty hard to argue if joint space is increased compared to placebo, then that means hyaline cartilage is repaired. So this is the best example that you can show to your medical doctor or whoever is making referrals or whatever, that it has the potential to do this. Yes, it's a small sample size. I get that, but you can't argue with objective findings. Sorry, you can't. So there's because well, it's not placebo if it's objective, right? So they looked at a whole bunch of different things, and what they found was so they looked at they did the treatment, and they looked at 4 weeks, and they looked at 8 weeks, and they looked to see if there was any significant changes in all these different parameters. What they found was that, yes, it did definitely help with pain compared to the placebo, but the before and after comparison of x-rays measuring the joint line, the joint space, sorry, they found that it improved cartilage thickness through biochemical changes, right? So this is the one great example. I wish we'd see more of them, but ethically, I think it's hard to pass these kinds of studies because of x-rays and whatever. So it's kind of challenging to do that, but this is one of the best papers I've ever seen in humans to show that it has the potential to improve hyaline cartilage thickness, which is the topic of today's webinar. Then there's this one that came out about 5 years ago. And it's kind of well, it's an editorial, and it's so it's not an actual research paper. And it says, is there a role for photobiomodulation in the treatment of damaged articular cartilage due to injury or degeneration? So essentially, what the authors do here is they look at sort of what's been published, and they talked a little bit about some of these papers, mostly in animal models kind of scenario. But what they found, well, first their statement is that photobiomodulation seems to have emerged as a promising option for management of cartilage damage. And photobiomodulation uses obviously light, and it could be LEDs, it could be lasers, and it can increase stem cell multiplication and differentiation, and finally modulation of function in cells. They concluded, when you looked at all the evidence, and I'm going to present some of those papers coming up, that photobiomodulation probably has positive effects on biostimulation on cartilage tissue. There might be a role for it in treating damaged articular cartilage due to injury or degeneration without eventual side effects or complications. So in other words, there's not enough evidence to say, oh yeah, everyone should have this and this is how you exactly do it. But it is certainly lending to that way, that it seems to have evidence showing that it's doing something and having an effect with no side effects, and it's safe. So like, come on, like why wouldn't you try it? Is kind of my scenario. So let's look at some of this research. This one was the effect of LLOT on osteoarthropathy in rabbits. And the aim of this study was to determine whether low-level laser therapy aided in the recovery of damaged articular cartilage in joints with artificially induced osteoarthropathy. I'm going to say OA, it's a little bit easier. These were the findings, essentially. So let's just, first of all, understand this chart. On the far left is the micro finding. So the histological, because they looked at it, the micro finding, like the articular surface, the cartilage, any degeneration, the tide mark, which is kind of how the cells look, the subarticular bone, if it's eroded or not, and what the cell structure looks like, the number of cells. In normal, hydrogen peroxide induced OA group, and then the laser treated group, so they induced OA, and then they treated with laser, and they looked at 2 weeks and 4 weeks, and then they also induced OA and did no treatment. Okay, so everyone's following me. Okay, so after 2 weeks with laser, you can see sort of what happened here. After 2 weeks, there were still significant amount of fissuring and fibrillation, which is kind of like erosions in the cartilage, kind of like little tiny like holes in it. The articular cartilage appeared still degenerated. It was present in the upper 4/5 of the joint. The tide mark of the cell structure was irregular and multi-layered. They noticed that the subarticular bone was regenerating compared to damaged. So there's some improvement after 2 weeks. And the cells were hypocellular, meaning less number of chondrocytes. Then the big thing here, and this is the clinical takeaway when you're using photobiomodulation or laser therapy, whether that's at home or in a clinical setting for clinicians, is that the effects take longer. So what they concluded, and I'll come to that in a second, is that after 4 weeks, that's when they started to see significant improvement, including the articular surface, which now is relatively smooth with just some small focal fissuring, so less evidence of articular damage, more improved organization of the cartilage. Now only 1/3 of the cartilage had degeneration, and it was more regenerated, improved cellularity, right? And then if you compare it to the no treatment, you can see that there was still the capacity for the those cells to repair for sure, but not as significant compared to the laser treatment group. So this is still the same paper. Based on our results and literature review, LLLT is effective in treating OA. And they made this claim based on, I didn't get into this, but SOD activity, simple radiographs, 3D CT images, gross observations, and histopathology. No significant treatment effect was really seen after 2 weeks, but they found significant improvement after 4 weeks of treatment. Okay, so that's the takeaway. If you're going to treat OA, it needs to be done consistently at least a month. And I'm going to talk about those guidelines, at least how I would approach it shortly. So they concluded they believe OA should be treated with LLLT for at least 3 weeks if you want to see some improvement. Then there was this paper on the effect of gallium aluminum arsenide laser irradiation on the epiphyseal cartilage of rats, like, politicians, for example. Oh, no, maybe not. So this was to study the effect of 830 nanometer wavelength. So that's traditionally near infrared. That's what we use at BioFlex. And they looked at, this is a good paper because they looked at 2 different dosages, 5 and 15 joules per centimeter squared on the epiphyseal cartilage of rats. And then they evaluated the bone length as well. It's kind of an interesting study because they measured the entire length of the bone. And then they also looked at the number of chondrocytes and thickness of each zone of the epiphyseal cartilage. And I'm not going to spend a lot of time on this, but this is kind of what you see in the control group with how they're all pancaked together in the active chondrocytes. That's kind of what you would see. And then these were sort of, on the left is G5, which is a 5 joules per centimeter squared. On the right was the 15 joules per centimeter squared. It's kind of hard to see here, but if you look carefully, you'll see a better result, more cells, kind of greater thickness of the 15 joules compared to the 5 joules, but both were effective. But end of the day, this kind of shows that more dosage, right, seem to get better results. Now, these are rats, right? I joked around politicians, so we're talking about little tiny rats that's easy to get light into. Humans is a different beast altogether, right? So that's where it's challenging to get light into the joint. And I have some tips you can try to improve that as well. I see you have questions. I'm going to get to those at the end. So, anywho, let me just back up a bit here. Sorry. Histological analysis and X-ray images revealed that this dosage, that gallium aluminum arsenide 830 nanometers induced an increase in thickness of the epiphyseal cartilage for both the 5 joules and 15 joules per centimeter squared, and especially in the 15 joules per centimeter squared, they had a much greater number of chondrocytes. They concluded that within the parameters they talked about in the study, it induced changes in the thickness of epiphyseal cartilage and increase the number of chondrocytes. I guess it's just saying what I said above there. Whoops. So anyway, how do we approach this with our equipment? Well, there's 2 options in our software. I'm talking to professional software here, okay? To treat joint degeneration. The first option is using the standard protocol that's for a joint, like the knee joint, for example, or ankle joint or hip joint. So you're going to choose this protocol. Now, the thing about that is that that protocol, you can make some adjustments to. And what I might suggest is that you increase the time of the red and the near infrared, especially on the affected side, by a couple of minutes. So for example, you're treating knee joint osteoarthritis. What I would do is the pad that goes on the medial aspect of the joint line, increase the time of the red and the near infrared by a couple more minutes. Instead of like 6 minutes, take it up to 8 minutes or thereabouts, just for a little bit more irradiation dosage, as these studies show. The other option is we have a generic degenerative OA protocol. And the difference for this protocol is that it has the increased timing and therefore increased dosage parameters. This was established by, Dr. Fred Kahn, who over the years, as he was treating OA, noticed that you needed more dosage. And that kind of falls in line with the research that I've been showing as well. So for example, here's the protocol for the knee joint. It shows different stages. I'll talk about that shortly. And it gives the time. So for example, 6 minutes red, 6 minutes infrared on the medial side, and the lateral side and the popliteal side. But what I'm suggesting is maybe increase from 6 to 8 on the affected joint side, whether it's medial, lateral, or both. It just depends, I guess, right? Whereas the degenerative osteoarthritis protocol, you can see here, it already has built into it a little bit longer time frame. And he also suggested that you can use more infrared. So like use red, but he's focusing a little bit more on using infrared, which kind of makes sense to get it deeper into the joint as well. With respect to using the laser probe, you want to hold the probe for a little bit longer on a joint line, anywhere from 10 to 30 or longer seconds per point. And there's a range. And part of this whole process is that I can't tell you exactly what to do. You need to see how the patient responds and adjust accordingly, because there's so many factors, including the size of your patient, the extent of the degeneration, and so forth. So start off with maybe 10 or 15 seconds per point on the joint line. And then if you're not noticing some improvement, at least symptomatically, then you might start to increase the time per point. And especially if you're treating like deep joints, like the hip joint or the knee joint, you might want to start with longer time, like seconds per point. Maybe start at 20 seconds or 30 seconds and work your way up and see how they're responding there. So really, it should be longer for bigger, deeper joints and smaller joints, like say finger joints, for example. If you do have an LDR 100, like the red laser probe, that's not going to go deep into a joint, but it can get into the synovium, which is really helpful for pain control and effects on inflammation. So I suggest if you do treat a lot of arthritides, that you pick up the red laser probe, because again, not going into the joint, but going into the synovium. All that light is concentrated into the synovial lining around the joint capsule. It's really good for that. So and that's where the array works as well too, but the red laser probe is also helpful for that. When you're treating any joint, make sure it's in a loosely or open packed position to open it up to allow whatever light is going in there to go into that joint as much as possible. Open packed as opposed to extended. So let's say a finger joint, don't treat it with it extended, treat it with it slightly bent to open it up a little bit. Same thing with a knee joint or a hip joint. Um, Treatment plan, in a clinical setting, usually your patient is going to come in 3 times a week for at least 4 weeks. At home, if you have the home device, I'm going to say treat 4, 5, 6 times a week with the home device. In a clinical setting, we have higher powered lasers, so that kind of, you don't need to maybe treat as often, but certainly 3 times a week, minimum twice, but I'd say for good results, 3 times a week. And, optimally 8 to 12 weeks. Again, that depends on the extent of the degeneration. When you're finding that the protocol and the treatment isn't giving the desired effect, maybe after 2, 3, 4, 5 sessions, you can slowly start to increase the parameters. Duty cycle, which is a dosage, you can increase that in increments of 10 or 20%. And the pulse rate, we're not quite sure exactly what pulse rate does, but it seems to have a better effect. So you can also play around with that and start to increase that in increments of 10 or 20 cycles per second or hertz as well. And of course, this is not an isolated treatment. You're going to combine this with other types of therapy, preferably, not drugs, but whatever, like exercise therapy, manual therapy, and other conservative, hopefully evidence-based therapy. Not everything's evidence-based. I'm not a stickler on that, because we all know that there's things that we do that help the patient, and it's not in some kind of, I'm not going to say stupid guideline, but not in a evidence-based guideline made by the American College of Physicians and Surgeons, for example, which I'm going to get to in a second on my rant. When you use the, is everyone still listening in? Okay, good. So when you use the laser probe, what I suggest there is that you make sure you have firm contact and push it into the joint line to get the tip of the probe as close and to that cartilage as possible, right? And when you push it in, you're going to get it closer, and that near infrared light can go into that cartilage to some degree. If it's bent, like at an angle or what have you, not paying attention, then you won't get as much light into the hyaline cartilage. Okay, so I got through that. Oh, that's not too bad. Now, we're having a masterclass coming up. That is on November the 9th. So we're doing a live event. It's a great venue just up in King City. Go to our website and hopefully everyone can attend. It's an early bird on. It's only $100, which you get an amazing lunch. Like it's just a high-end, this is the same place we did it last year up in the Kingbridge Center. So it's like a wonderful lunch that they give you. I'm not focusing on the food, although I kind of like the food, but a whole day event. And we'll be doing giveaways. So for $99, I think it's a deal. If you're free that day, even part of the day, try and join us. We'll also be broadcasting live online via, I think, Zoom. So if you can't make it, you can watch. And after the fact, we'll be recording and edit it to be made available on our website as well. Guest speakers and topics. So the theme of this masterclass are difficult, challenging case studies and protocols experienced BioFlex clinicians used to help these patients. So the takeaway is clinicians will get protocols to customize into their software that some other clinicians have found very helpful that perhaps you might want to use as well. So Ben Ewan, of course, our star, will be talking about meniscal tears, spinal stenosis, Achilles tendinopathies, and compression fractures. So he's going to walk through exactly the protocols he's used. And by the way, you can ask lots of questions, both online and live in person, not just about these specific cases, but other cases as well. We'll do that at the end of the session. He's doing a bonus lecture on how he integrated laser therapy successfully. And to be honest, Ben has a tremendously successful, mainly laser therapy practice in Halifax, Nova Scotia, where he has treated tens of thousands of patients, has, I don't know, 20, 30, 40 systems, and has done so well with laser therapy. So I'm going to share some of that with you as well. Also, via South Africa, Dr. Karen Miller, a chiropractor, she and I communicate a lot, and she's been telling me about some of the great cases she's been seeing. And so I said, well, why don't you share some of those with our audience? So she's going to be talking about, she oftentimes combines ultrasound with laser therapy and seems to have really great results on ankle sprains and repetitive strain injury and lower extremities. So she's going to talk about a couple of case studies from South Africa live. And then Melinda Couch, who is a physical therapist from Boulder, Colorado, well known for her work with the Olympic figure skaters on the Olympic USA team. And she's going to be, but she treats all sorts of things. So she'll be talking about success with a patient with early onset Alzheimer's, autonomic nervous system dysfunction, as well as a post-concussion syndrome from a figure skater as well. Again, remember you'll see protocols and their take on how they treated these patients. So if you use our equipment, I really highly suggest that you attend that day. David Barker, an RMT out of Kingston, he shared this really interesting case, not necessarily something you would treat as an RMT, but he saw this really amazing result with adrenal insufficiency, and he said, "Hey, Dave, he just wanted to share this with me." And I said, "You know what? Let's present it at the masterclass because I think it will be of interest. It comes up sometimes, and to see that anecdotally it helped, should be pretty fascinating." I'll be speaking. Slava Kim will be speaking. He's our clinic director at the BioFlex Clinic in Toronto. And also you'll get a look at our latest devices and maybe a sneak peek into some of our new BioFlex devices that are coming in through the pipeline as well. Okay, so here's my rant of the day if you care to listen in. I was sent this article from one of our BioFlex people. Anyway, we wanted to find the best red light therapy device to help with pain. Here's why we can't recommend any. And it was a wire cutter out of the New York Times. And funny enough, so I responded to this article to the author, and I got a response just before I started this broadcast. So I'm going to share this. Now, in all fairness, This person was looking at home devices to use for pain, okay? But she referenced a lot of research, right, that wasn't necessarily using home devices, but the premise is the same. Regardless, is when you read through this article and how she presents it, I thought it was biased, even with her response back to me. She didn't address my concerns, right? And so I'm going to start with a couple things. She mentioned that she reached out to pain experts and none of them would recommend this type of therapy. So I said, well, like that's interesting because there's many pain experts out there that do highly recommend photobiomodulation therapy. For example, Roberta Chow, a medical doctor and pain specialist out of Australia, that did a highly reviewed meta-analysis and systematic review on neck pain in the Lancet. But the author chose to ignore that. And when I brought it up, again, she didn't mention that. I mean, this is the Lancet. It's one of the most premier journals. Her response to a lot of my things were, oh, it's outdated. And to be honest, an evidence-based guideline is not outdated until it's replaced, right? So if you see an evidence-based guideline and there's not something new out there to refute or whatever the evidence, it's there. So her response was, well, when she reached out to some of these experts or these guidelines, they said, oh, well, no, we don't recommend that anymore. But there's no new evidence-based guideline to suggest that. So I'm not really sure how that works, but that's not how guidelines are supposed to work, right? And I did recommend to her, I said, there's guidelines by the American College of Physicians and Surgeons on non-pharmacological ways of treating low back pain that recommends laser therapy. She goes, well, I reached out to the ACP and they said, well, to be honest, that's outdated now and we don't recommend that anymore. Well, okay, so the guideline is there. It hasn't been replaced. Why on earth would you say that? Like, and what is that, off the record? Like, who's saying that? Did the authors of the guidelines say that? Like, to me, that doesn't really hold much water. And then when I mentioned these other things, she goes, well, they're all outdated. I'm like, well, yeah, but guidelines aren't made every 3 or 4 years. So sometimes take a decade to actually manifest and come out. So I don't really buy that argument. She also said, well, despite thousands of studies, research still lacks definitive answers whether it helps with pain. And some studies show a benefit and others do not. Well, that's not really true anymore. Like early on, like decades ago, when they were looking at laser therapy and light therapy, they didn't really know what they were doing. So the dosages were all over the map. And to be honest, you get researchers that didn't know anything about what they were doing, and they didn't use correct wavelengths or dosages, and they didn't get good results. And now the vast majority of clinical research trials that use what we consider a window of doses that's effective, they get positive results. So that does not hold water at all. If I were to look at the last 5 years of randomized control trials published on PBMT, you would only find a handful that were negative. And typically, when they're negative, there's editorials that come out from experts in photobiomodulation that say, well, they didn't use the correct dosaging anyhow. So what would you expect, right? But again, she's not agreeing with that, for example. And lastly, she mentioned that study methods vary widely, and this is part of the problem improving efficacy. Well, that's true to some degree, but not really true because the most important parameters are wavelengths. That's well established. Red, near infrared. No argument there. That's what's been used for decades now. So you can't say that's not something that varies widely. It doesn't vary widely. It's in that range always. And then there's, like dosaging. Well, they now have gotten a window of dosaging that if they use that most of the time, it's effective. So that's kind of established. Where there's varying things or things like, she said, treatment time. Well, treatment time is just a factor of dosage. So the longer the treatment time, the more dosage. I mean, it all plays into the energy density, and we know what's going to be effective for that. So to be honest, I really did feel that it was biased. But she's talking about home devices, and I get that. Our home devices are based on our professional equipment, and we've seen really good results with it. I can't speak to stuff you buy off Amazon and other cheaper devices, and maybe that's what more she was going after. But had she kind of looked at home devices made by medical device companies like ourselves, then I think it's a slightly different discussion to be had there. Anyway, that's my rant for the day. I'm just going to see if you have any questions here. Is there a protocol to use laser along with PRP? Not a specific protocol but you can use it after PRP to help. And there's some papers to show that it helps synergistically with PRP injections. So just use a standardized protocol for that joint that you're treating, and it should be helpful. Okay, someone said human studies. Well, I did present one human study. I know, unfortunately, when you're looking histologically, when you have to do invasive things to look at the cartilage or X-rays, you can't do it on humans because ethically it won't pass the ethics board. So that's why you don't see it typically in humans. So they did in Saudi Arabia, but maybe they're slightly different guidelines there. Um, Someone's mentioning here they've had 3 Synvisc treatments over 7 years with great effect. Yeah, I've heard some good things about Synvisc for sure, and also mentioned that photobiomodulation has also helped. And so yeah, so I mean that's what I'm talking about. Try different things. Synvisc, I've heard also good things about, but again, same thing with laser therapy. It doesn't help everyone to the degree that maybe you'd like. Masterclass is available virtual. Maybe you should suggest and try it then. Yeah. Yeah. Maybe I'll send her a sample device to try for her to try. But she seemed pretty curt with her response to me, but that's kind of expected. Can your conference speakers be recorded and posted on your website? I mentioned that they will be recorded on our website as well. If you can join in live, that's ideal because you can ask questions as well. Thanks everyone for joining in today. I really appreciate your attentiveness and time. And I'll be putting up a list of new webinars coming up shortly after our masterclass. And I hope to see all of you or most of you at the masterclass or at least virtually as well. Really appreciate your time today. Take care.